All right, so we'll start. I have the distinct pleasure of introducing John K. Luther and Dr. Frank O'Brien. So Dr. Luther is one of our second year residents in internal medicine at WashU. She has a wonderful adrenal case for us, and we will be having an expert consultation with nephrologist Dr. Frank O'Brien from our nephrology department. So, Janaki, why don't you share a little bit about yourself, something you do for fun outside of work, and then we'll get started.
Yeah. So fun fact is I actually know Mohit from undergrad as well. But I'm Janaki. I'm from Massachusetts. I couples matched here with my husband, who's an anesthesiology resident. And for fun, I just like to try restaurants in St. Louis, but apparently there's not much Italian food here. So I guess I won't be trying Italian food.
What do you have in store?
Italian food.
Okay. Why don't you start us off, Janaki? What's the chief complaint?
Yeah, so this is the chief complaint, I guess, is an adrenal mass. It was a 58-year-old female who came to an outside hospital initially and then was transferred to Barnes for further workup of an adrenal mass.
Are we supposed to ask her questions, or is she supposed to ask us?
No, she'll give us all the information, then we'll pause.
Okay.
So, Janaki, why don't you just complete the HPI and maybe the review of systems, and then we'll pause.
Yeah. So she initially presented to an outside hospital for a CHF exacerbation. She was having some shortness of breath and lower extremity edema. At the outside hospital, she also had imaging done because she was complaining of abdominal fullness and pressure for the last 3 months. And then on the imaging, they identified a left adrenal mass along with some fibroids. She didn't really have any other symptoms other than that low extremity edema and the shortness of breath. So once she was diarrhea, she was transferred to Barnes for workup.
Okay. Dr. O'Brien, do you have any thoughts about just in general when you hear adrenal mass and maybe a background of CHF, if how much investigation needs to happen?
So there's two things I'm thinking of straight off. Adrenal mass, I kind of divide into adrenal incidentaloма versus, oh, maybe it's something real. CHF exacerbation in a 58-year-old, not really that exciting. The abdominal pressure by 3 months, hard to break much into that. Fibroids question, what's that about? So is the working theory right now, the abdominal pressure is from fibroids? Or is there another question in your like HPI? I won't go past HPI right now, but.
Yeah, I think fibroids were kind of the explanation for the abdominal pressure that she was having.
Okay.
Yeah.
And what I would ask, like another question that I would normally ask is like, well, okay, you've got CHF, like have you lost weight?
No weight loss.
Okay. Headaches?
Mm-mm.
Okay. On any medications? I guess that's the next step. So I'll wait for that for a second. Flushing, nausea?
No flushing, no nausea.
Nothing that would explain this adrenal issue.
And I will kind of let you know she wasn't the best historian, so getting some more like targeted information out of her was kind of difficult.
Okay, poor health literacy?
Yeah.
Co-patient?
No,
Oh.
surprisingly.
Okay, interesting.
So, Janaki, was this adrenal mass something that was new on the imaging, or was this adrenal mass that she's known about?
So they had seen it on a prior scan before, but it appeared slightly larger on this imaging.
Oh, so that makes me worried. Because if it's an adrenal incidentaloma, right, you should just be seeing the same thing every 2 years or so. Okay.
What else you got for us?
Family history of anything?
Nothing significant, no.
Yeah, Travis is asking what's the number?
The size,
Yeah.
so it was 6.3 by 4.4 centimeters.
Okay, so that's pretty huge.
And then she had another 4 centimeter nodule located anterior to the left renal hilum.
Oh. Do the kidneys look okay on this imaging that was done?
Yeah, the rest of the kidneys looked fine. There was really nothing else noted.
No history in the family of unexplained strokes or anything like that?
Mm-mm.
Why do you ask that, Dr. O'Brien?
So you tell me. Why did I ask that, Yankee?
No, I asked first. You can't punt the
Not how this works.
Let me give you a clue. Mohit is playing the chief card,
He is, I know.
and he gets to play it for a year.
So what I think is we always have to think kind of like laterally and outside the box a little bit. So someone's put in a very broad differential, but if there's a history of strokes in the family that we don't know about and there's some abnormality, even if it's not that abnormal in the kidney parenchyma itself, I always like to think to myself like, oh, could this be unexplained polycystic kidney disease? It will be unusual, but it's a good negative. A negative to think about that the person does not have intracerebral hemorrhage from a what you call it, very aneurysm. But obviously that's not the case.
Janaki, anything else relevant in the HPI about her or in the review systems?
No, really, there's like, she didn't really have many complaints at all when she came to us, and no like positive review systems other than kind of what we've mentioned.
Okay, so
Okay.
why don't we go through then the past history, meds, all that stuff.
Yeah, so for past medical history, she has hypertension, CHF, it's mostly diastolic dysfunction, COPD, she's on 3 liters, HOMO 2, type 2 diabetes, GERD, these fibroids that were noted on imaging, and then also schizophrenia, which is why some of the history was difficult to obtain.
So I will ask here, if this person was 38 years old and was referred to you with this this kind of story, how would you change your approach to your diagnostic workup?
Are you asking me or anyone?
Anyway,
Okay.
let's ask Mohit.
I guess 38-year-old and you have maybe an adrenal mass, that would make me maybe consider like a genetic syndrome or some type of like cancer syndrome. I'm blanking on the ones that cause the adrenal.
So think more like, just keep it simpler. Like let's say it's an adrenal incidental in a 38-year-old, but she is also hypertensive, which we're going to get into like later. I know we're
So
in a
then,
different
like-
workup, but
So
like
then,
what's the
a hypersecreting nodule in the adrenal that could be causing the hypertension?
what's the commonest, like what's the textbook hypertension young person female with abnormal adrenal labs diagnosis?
I'm gonna punt this because I honestly don't know. I'm blanking.
So fibromyalgia or FMD, right? So you're thinking of like fibromuscular dysplasia of both renal arteries, both causing hyperrenemia and hyperaldosteronism. But that's a thing we should think about. But in this case, we have more red flags than just to like cause it to say it's this. Anyway, sorry, I interrupted your flow.
Yeah. So fibromuscular dysplasia would have adrenal issues along with it. That I didn't know.
Yep, you'll get bilateral. You'll get hyperrenemia, hyperaldosteronism. Just like in an old person, you'll have bilateral atherosclerotic renal artery disease. You'll get both again. Anyway.
Janky, do you want to round out the meds?
Yeah, so she's on albuterol, aspirin, atorvastatin, vitamin D, famotidine, metformin, potassium supplement, trazodone, venlafaxine, Coreg, Lasix, losartan, amlodipine, and paliperidone, and a norelipta as well for another inhaler. But
Family history said none. Any major surgeries?
No major surgeries.
Okay.
So social history, she smokes a half pack per day, unsure for how many years she smoked for. And then she lives in a nursing facility.
Why don't we pause there and kind of discuss the differential diagnosis? Because I think
Lot to
we have
unpack.
a lot of information at this point, and we should think about how we should tackle the workup of this patient. Dr. O'Brien, do you have any thoughts?
Yeah, so I mean, we haven't gotten to the labs yet, but this person's on, was it 1, 2, 3, 3 antihypertensives plus diuretic? Is that right? Am I missing the fourth?
Yeah, lodipine, coreg,
And then she's also like the fact that one of them is losartan and on potassium supplementation. So something's not right here. She should not be on potassium supplementation. And I assume we're going to learn in the labs that her potassium is either low or low normal. It's kind of very odd, but definitely is a sign that there's some Renin-Aldo issue going on, whatever it might be at this step. Yeah, so Kushal has a good point suspecting hyperaldo. If we see it, what would we expect to see? Like if we're going to predict the labs, what should we see in the labs that would make us think it's a secondary or primary hyperaldo picture, which is kind of pointing towards right now. So we should see, right, low K, high bicarb. But we're all predicting here. It's not. Yeah, I like Tiago's thought. It could be a renin secreting tumor. Could be Conn syndrome or something like that. Cushing syndrome, that's a good call. That's a good thought, yeah. And I agree, someone mentioned already serum metanephrines. That's important because it could be Theo. There's lots of interesting differentials here. So are we going to examine her?
Yeah, we are. Dr. Centaur, do you have any thoughts on this up at this point?
Yeah, I do. I think one of the things that we often forget in past medical history is time course. And so I'd be interested to know if it was possible how long she's had diabetes and how long she's had this bad hypertension, because that the possibility of Cushing's would go up if all of a sudden she developed both diabetes and hard to control hypertension along with hypokalemia, and that might be a clue. And it's one of the things that becomes very clear to me is that we give past medical history and we don't. And people have heard me say this before. We give the nouns, but we don't give the adjectives. So we did get the adjective for the CHF. I assume we're assuming this is HFpEF. But anytime I hear diabetes, I want to know how long they've had diabetes, because I think totally differently about someone who's had diabetes for 2 years, somebody's had diabetes for 15 years. They just have different stuff. I would like to know how severe the heart failure was. And it's interesting, she had a heart failure exacerbation with lower extremity, which means that she probably had some right-sided heart failure. So it's much more complicated than just writing down that PMH. And I just think that's important for us to always think about when we're teaching and trying to understand the patient.
Absolutely.
And I guess with regards to that, I don't know how long she's had diabetes, but it seems like the hypertension was kind of like a persistent problem for years.
And Dr. Centaur, I know you've been, through primary care and then hospital medicine through your career, and you've probably seen your fair share of adrenal masses. In hearing her story so far, how would you kind of deal with a patient who comes to you with an imaging finding like this?
Well, the imaging here was incidental, but I'm really interested I'm interested in the basic metabolic panel, but I'm always interested in the basic metabolic panel because I might learn something from it. And that might make me go someplace. I would also need to know, is her blood pressure fairly well controlled on this regimen? How did she get, is she on the carvedilol because of is she on the carvedilol because of the heart failure, or is it because that's the only way they could control her blood pressure? If I was doing when I was doing primary care, I would know all those things. Now I have to try to search through the chart to figure those things out. So it's the context of the patient. I don't have a good way to work up the adrenal mass. I have a good way to work up the patient.
That's a good
I hope.
Why don't we go forward with the exam, Jonathan?
Yeah. So for vital signs, her temp was 97.7, blood pressure 170 over 102, heart rate 67, respiratory rate 22, and then she was satting 95% on 3 liters nasal cannula.
Is that her baseline?
That's her baseline. Yep.
Good.
And then for exam, she was in no acute distress. For AT&T, she had no cervical lymphadenopathy, moist mucous membranes. Cardiovascular, regular rate and rhythm, no murmurs, rubs or gallops. She was clear to auscultation bilaterally. For GI, she was non-tender, non-distended, but you could feel the fibroid uterus kind of in the lower abdomen on palpation. Skin, no rash, but she had 2 to 3 plus edema up to her thighs. MSK was no abnormalities, 5 out of 5 strength. And then for neuropsych, she was like A&O, kind of fluctuating like 2 to 3, but otherwise cranial nerves intact.
Why don't we give them what they asked for? They want the BMP.
Okay, so the sodium was 140, potassium 3, chloride 97, bicarb 40,
Uh,
BUN 13, creatinine 0.8, glucose 130. And then white count was 9.9. Hemoglobin was 13.1. Platelets 228.
okay.
Okay. Well, Dr. O'Brien, I think you, in some ways, predicted this, huh?
Yeah. So we got hyperaldo.
Yeah. So can you walk through for the audience the physiology of why you were able to predict that?
So if you think about it, the adrenal gland this adrenal mass is probably secreting aldosterone and suppressing renin. And therefore if you think about your distal convoluted tubule, you're going to be excreting a lot of potassium. And in exchange, your distal tubule is going to be trying to conserve acid. So you're going to be retaining bicarb. And that crazy bicarb of 40 is pretty huge. And the next question you've got to ask yourself is this something that is either due to a primary adrenal abnormality or a secondary adrenal abnormality? And I think that's going to be part of the thing we're going to work up. And obviously, the first step to check that is to check a renin and an aldosterone level. There is a caveat in this because she is on some kind of ACE inhibitor, right?
Yep, she's on.
ARB.
Yeah, losartan. Yeah. So we're going to be a little bit screwed because we can't take her off losartan, right? Because she's got a blood pressure of 170 over 100, which is crazy. So you're going to have to temper any results you do or any tests you do based on the fact that she's on a blocker of ARB. I also agree with everyone who's commenting that we should also have not like completely anchor our diagnosis because you do have to think about things like Cushing syndromes, pheochromocytoma, although I would put them way down on my list now. I think now we're fishing for the cause of our hyperaldo state. And that's the next step. The next step is to check the actual aldorenin levels. Then thereafter, you're kind of going to think about, I mean, I'm kind of rushing ahead here. We should be thinking about whether we should do adrenal vein sampling and all that kind of stuff. But
And
what was your next?
Yeah, I was just going to say the exam outside of the edema in the fibroid uterus, pretty normal. Would there be something on exam that could clue you in for a hyperaldo state? Not that I can think of.
Not that I can think of, to be
Well,
honest. But
no, I think you always have to think about hyperaldo when you have difficult to control hypertension.
Yeah.
Yep.
In everybody, whether their potassium is low or not. And I can refer you to a number of podcasts that I've done on that.
I was about to say, you've talked about this plenty of times.
Yeah.
Yeah, it's sorely underdiagnosed. Okay, well, Janaki, what labs?
What did you do?
Yeah.
Do you want all of them all at once, or should I
No,
go?
tell us how you did it. What was your thought process and how you worked it up?
So we kind of had the same thoughts. The bicarb was really, really high and the K was low. So we were also worried about aldosterone secreting tumor. So we started with that. And then we also consulted endo and they recommended some labs as well. So I can start with the serum aldo and renin if you guys want that. So the serum aldosterone was 30.
Oh, that's high.
And then the renin activity was less than 0.6.
Well, we have a diagnosis.
Well, we're done then.
We're not done.
Go on.
And then endocrinology recommended getting like workup for pheochromocytoma, Cushing's, and all of those as well. So for workup of the pheo, the plasma norepinephrine was elevated at 1.3.
That's that's borderline high, right?
Yeah. Metanephrines were normal at less than 0.2. And then we also got urine studies. So the urine norepi was 106, which was elevated.
How elevated?
So normal is like 15 to 80.
Oh, okay.
And then epinephrine was 3.2, which is normal.
Okay.
And dopamine was 371, which is normal. We also got ACTH and dexamethasone suppression test. So the ACTH was low at 5.1, like borderline low. And then the low dose dexamethasone suppression test, the AM cortisol was 6.1, so it was not suppressed.
This is getting complicated.
And then we also got urine cortisol, which was 16, and the urine creatinine at that time was 1.1. And then endocrine had also recommended getting like hydroxyprogesterone, testosterone, DHEA. So testosterone was low at less than 7. The 17 hydroxyprogesterone was normal at less than 40. And then the DHEA was normal as well.
I don't know how to interpret the second half of all your stuff, but I think, can you attribute the, like, correct me if I'm wrong, can you attribute the metanephrines and the urinary catecholamines as being normal, more or less?
Yeah, so when we were like looking into this, I think they have to be elevated to greater than like 2 times the upper limit of normal to be considered like in the range for pheo, but the endocrinologist should correct me if I'm wrong.
Tiago, please weigh in.
Yeah, we don't know.
Yeah, so for pheochromocytoma, you have to have at least 3 times the upper limit of normal to consider it. So otherwise, just forget it.
Yeah, that's what I did 1 year endocrinology fellowship, and that was what I learned. It's never a few.
I didn't know that.
Many things
Yeah,
are
so
unusual about me.
Pheo is very rare, and catecholamines, metanephrines are really high, really, really high. So I didn't get, but it's less than 3 times the upper limit, right?
Right, yeah.
Yeah, for sure.
And then, Tiago, if you don't mind explaining kind of the lower half, the hydroxyprogesterone, testosterone. I remember flow charts in med school, but honestly, I haven't had to send out those labs ever.
Yeah, so progesterone, it changes based on ACTH. So it depends a lot on ACTH. So for this reason, when you have congenital adrenal hyperplasia, you have high OH progesterone because of this being high, it suppresses ACTH, and then you have a low ACTH. Oh, actually, you have a disease. You don't have cortisol. As you don't have cortisol, ACTH is high, and then 17-OHP is high. This is CAH. I was studying it wrongly, but it depends on ACTH. We use it to diagnose CAH, congenital adrenal hyperplasia, which can be classic or non-classic. But here it just gives a sense of adrenal function to produce hormones like cortisol. But it doesn't bring a lot of information. There are some tumors producing OH progesterone, but it's not common. And testosterone and DHEA, they are normal, and they are usually normal because there are these tumors, but they present with virilization. So for women, you won't expect a virilizant tumor without virilization. So as there is no clue for virilization, we just order it, but it's
the wrong
expected
age,
to be
right?
normal. Sorry?
The age, like 58-year-old woman at this stage would not be having any of those things, right? Or maybe
Yeah,
this is being
if
not,
she had
not
a tumor,
endocrinologist.
a virilizant tumor, she would have many symptoms like muscle mass, libido,
Okay.
horse,
Growth hair,
yeah, horse wear. So it changes a lot. There are many clinical implications.
Okay.
Dr. Centaur,
Yes.
any comments?
Yeah. First of all, I don't understand the urine creatinine. Is that 1.1 is not a urine?
So what does that mean? What does that mean, Mohit? What's a urine creatinine of 1 milligram per deciliter? I assume it is mean to you. Means nothing.
Yeah, I don't know.
Well, it's never that low.
It's basically an inaccurate sample.
Yeah.
It doesn't make sense.
I'm going to go into this in a future episode, sometime in August or September. But if you assume that we perfectly filter creatinine, and then we neither secrete nor reabsorb, which is a lie.
Yep.
Then the urine creatinine has to go up with water reabsorption. We normally reabsorb well over 90% of the water that we filter. Otherwise, we'd be peeing constantly.
Yeah.
So a normal urine creatinine to plasma creatinine ratio is going to be above 50, often 100 or even higher. Well, this one is 1. That's impossible. So unless we have the units wrong, we probably have the units wrong, because I'm sure you wrote it down right, but the units should be this. You should have it in the same units as you have the serum creatinine. So that just bothered me because I can't control myself.
I'm guessing that this urine sample that was given was probably, like, if they did all these urines, like the catecholamines and all that kind of stuff, they probably pipetted out one sample to do a creatinine, and it was dissolved in like 3 liters of urine or something like that. Which would make more sense.
Yeah, they did 12 urine studies at the same time. So
yeah, so that's
yeah, but the urine creatinine is really probably like 110, and so instead of doing milligrams per deciliter, maybe it was milligrams per liter.
Who knows?
Which is why the number is confusing. But what's the thing that I didn't understand, the cortisol. Was this a cortisone stimulation test? And what do you mean by not suppressed?
dexamethasone suppression test.
Dexamethasone suppressed. So dexamethasone did not suppress it. That's not real high, but it should be totally suppressed. So we're still thinking about a mixed cortisol and aldo in the tumor, which would be a little bit more interesting and a little bit more unusual, because I think we've cinched the aldo part. The other thing that back in the history, you said no weight loss. Did she have weight gain? Because usually if someone has increased cortisol, they might have weight gain, and and maybe you just hid it from us, but you didn't have a hump. You didn't mention anything else that often goes with Cushing's.
Yeah, she didn't have the hump. I think the weight gain that she had, she probably gained a few pounds from the edema, but it was nothing like significant. So yeah, other signs.
But she needs a good endocrine surgeon. That's what she
So
needs.
did you do adrenal vein sampling next, or what did you do next?
We actually didn't know. So should I go ahead and say what we did, Mohit? Or
Of course, go for it.
So first we started her on aldactone to see if that would help with the blood pressure and the bicarb. It helped a bit actually. And then we consulted endocrine surgery and they did a left adrenalectomy and nephrectomy
Oh,
actually.
wow. Okay.
And was there like imaging or anything else that was done prior to the surgery?
Yeah, so there was a PET CT done, and it just showed activity of the left adrenal nodule, but it basically just said not specific.
Not
Could
helpful.
like see, yeah, not super helpful.
So Mohit, adrenal venous sampling is good when you have a ACTH dependent Cushing syndrome. For this case, it is not ACTH dependent, so it will not add value. I think that's the reason they didn't do it.
They sometimes do that for aldo, but in talking, because I've done several podcasts on this, apparently it's very variable from hospital to hospital. And there's some places they do it real well and other places where it's not as good. And it's a little bit controversial. What they're trying to do is figure out which of the two kidneys, this is when you don't have an adenoma, because there's most hyperaldo does not have an adenoma. And to try to figure out where it is, they sometimes will do renal vein sampling, but according to the experts, it's not that good. And so treating with spironolactone or pleuronone really is what most of the people are doing if you're just treating hypertension and there's not a mass.
Dr. O'Brien, do you have any thoughts?
No, I agree. Generally, I would just out of being purely anal, I would do adrenal vein sampling, but I think the diagnosis is pretty clear. There is an hypersecretory adrenal situation. We need to get rid of it.
Right. John Key, anything else in the hospital course before we get to the surgical path?
No, that's pretty much all I had.
Okay.
Well, so clinically, after they take out the mass, is the blood pressure a lot easier to control? And that's why you need an endocrine surgeon, because it gets really tricky when you're taking a mass out that you think is secreting something, about how you adjust medicines and how you follow them after that. If you believe that the aldo was driving the hypertension. So I'm just interested if you happen to know what the surgeons did in that situation.
I actually don't. I could go back and look at the notes at some point, but I'm not sure.
Yeah, I think once she got the surgery, she probably went to the surgical service and was discharged via
Yeah,
that.
exactly.
Up north, right? I guess.
Okay, so what did the final surgical path show?
So surgical path showed an adrenal cortical adenoma, and then they did a bunch of different staining techniques, and it actually didn't show any hypersecretion of anything.
What? Oh my God. Does that mean anything?
So she followed up with endocrinology afterwards, and they weren't really sure what to make of it, kind of like us right now. But they are treating her like it was an aldosteronoma.
Okay.
So the question is, if she still has severe hypertension, she still has hypokalemia, then because most hyperaldo is not an adenoma.
Mhm.
That's the biggest thing that I've learned over the last 2 years, is that most hyperaldo, we discussed this in one of the podcasts I did, is you get islands of aldo producing cells within the adrenal gland. And so she still has an adrenal gland on the other side, and that they continue to be autonomous and secrete aldo. And just because you have an adenoma doesn't mean that was the cause of the hyperaldo. Now, would the renal vein sampling would have helped? Could you have saved her surgery? I don't think you could have saved her surgery in this situation, but you're probably going to have to treat her with spironolactone or pleuronone to control her blood pressure. But you could have predicted that even if you hadn't worked her up, because she had such severe hypertension. And that's the mistake that we're all making. We're all making the mistake of not being aggressive enough in considering severe hypertension deserves a trial of a mineralocorticoid blocker.
So this is a question for Mohit or Yankee. What about an ENaC blocker? How would that make any difference in this case? Do you think
Well,
that
it
could
would
help?
Your electrolytes, right? But it would,
Mhm.
you'd still be secreting the aldosterone. So I don't think it would affect the potassium, but someone in the comments is saying it won't affect bicarb.
How wouldn't it? Explain.
This is why I'm not going into nephrology.
I know, I'm actually.
What? It's fun.
Pushing me farther and farther away, Dr.
Yeah. So if you block the ENaC with like amiloride or triamterene, you might be able to hit. Have you heard of the maxi K channel or big K channel?
I don't think so.
It's like there's two channels that affect potassium secretion or excretion. One is, as we all know, the ROM-K channel in the distal tubule. And just slightly above it is this channel called maxi K or big K. That's flow dependent. And you also excrete potassium that way. And if you can block that in certain circumstances, kind of like this, which is kind of weird, you can overcome the potassium excretion problem and therefore also stop the H plus exchange problem as a kind of a trial. I've come across this like maybe 2-3 times. It's kind of fun to try it out. Because like what's the harm in switching out her spironolactone for amiloride? It's going to do the same thing. It's going to treat her blood pressure, but maybe you can get the potassium and bicarb under better control.
Yeah, I'm going to pile on and just give one of the pathway studies. I think they're called pathway. These were the studies of malignant hypertension and resistant hypertension. Resistant hypertension. So the 4 drug people, and in people who couldn't tolerate the mineralocorticoid, they tried amiloride, and it worked just as good as the 4th drug.
Yep.
So that no one's 100% sure, because it's just that one study, but I really love that idea that you mentioned, that's something for us to think about that I think is important for us to think about. So thank you.
You got my head spinning and I have nephrons going as floaters in my eyes. So now
You should be a nephrologist. Mohit.
I'm going to sleep really well tonight. Janaki, was there a pearl that I think you had told me about with the venlafaxine and some
Yeah.
of the labs?
So apparently venlafaxine can lead to false positive elevation of like metanephrines.
Oh, that's really cool.
So that was the explanation for why she had the slightly elevated norepinephrine and things like that.
Yeah, that was something I had never heard of. Tiago, have you encountered that or heard of that before?
No,
Fair enough. It does make sense though if you think about the pharmaceutical biochemistry of it.
And then I think she had one follow-up at least with endocrinology and saw Dr. Clutter,
Mhm.
but I don't think she's had one since, from what I could see in the chart.
Yeah,
It-
she didn't have any more follow-up after that. It was just that one visit and she was still on the spironolactone. So they didn't repeat any of the studies with the aldosterone and the renin since she was on the spironolactone.
You have the nice thing is you have two great clinical biomarkers. You have her potassium and you have her blood pressure. And if the potassium is not low and the blood pressure is good, then she's on the right dose. But the one thing that we have to consider in her, and this is something that I teach all the time, is that spironolactone has different doses for different situations. And just to give you the history, up until the Rouse trial came out, the only time we ever used spironolactone was for cirrhosis, and we were starting out with 100 milligrams per day, and then moving up as necessary in people with ascites. When the Rouse trial came out, that was the study that showed that 25 milligrams of spironolactone would help people with severe heart HFrEF. There was the nephrologist went crazy writing articles about all these people coming in with hyperkalemia to the emergency department because they either started them on the wrong dose, or they didn't notice that their creatinine was a little bit elevated and you really can't do it. And definitely they didn't even check the potassium after they start them on spironolactone. But in this situation, you may need a higher dose of spironolactone or pleuronone because you're secreting all this aldo. And so you have to give enough to counteract the aldo. Did I get that right?
Yeah, you did. Except for the crazy part.
You rarely go crazy, but they were just buffing their CVs. I'll say that. No,
It's true. No, you're right. You're right. I'm just making fun.
It was very interesting at the time to see all these articles come out about the increase in emergency department hyperkalemia, which I think everybody has under control now. But for a period of time, it was a huge emergency department problem.
Yeah. And the reason was, yeah, as you said, the Rails trial excluded anyone with CKD. So
yeah, can I just say a few words? I completely agree with you, Dr. O'Brien and Dr. Center, about the adrenal venous sampling for hyperaldo. When I said I wouldn't ask it was because she had a mass of 6 centimeters. As you said, it won't save her from surgery. So it needs her situation demanded a surgery. And also just because it's an endocrine situation, don't forget that she needs cortisol after her surgery.
very important.
And yeah, it's important to remind. And I believe they will work her up. I would like to see her aldosterone and her cortisol at this time. I maybe they will do it in the near future because it's a very, very weird situation. Maybe it was producing cortisol. It's weird that the pathologist should see it with the immunohistochemistry, but it's weird.
I agree. It's quite strange.
Janaki, did you have any other teaching points or take-home points that you took away from the case in real time?
No, I feel like I learned a lot just kind of listening to this discussion today. But I feel like I learned a lot about the workup of like a pheo and an aldosteronoma, and I don't think I'm ever gonna have to like do it again, to be honest. So,
Sure.
it's good.
Yeah, good. Any closing remarks, Dr. O'Brien?
No, this is a really cool case. It was fun to talk about.
Good, good. Dr. Centaur?
I'm giving WashU an A+.
Well, good.